Hi friends, this is Dr. Srinivas Samavedam. I'm one of the members of the Kriti Learn Learning Group and also the administrator of the Hicks WhatsApp groups. I'm also the organizing chairman of the Hyderabad Intensive Care Symposium. Thank you all for actually sharing your views and thoughts on what is the best way to engage with each other in this platform of learning and information exchange. As we have shared our information and our thoughts, it is probably good to have talks without PPTs on common topics, and it's also probably good to have case-based series of MCQs. So, as has been requested and suggested on the Kriti Learn group, we will start the first of this video talks on arterial blood gas analysis. Most of you who work in intensive care would know that now arterial blood gas is a clinical sign in critical care. So no patient's presentation or case discussion can be complete without knowing the acid-base status of the individual, and that's probably the context in which we will talk about arterial blood gas analysis. The principal and foremost point which all of us should remember when we interpret blood gases is that it is a point of care and point of time test. That means if I am looking at an ABG done on my patient now, it means that it represents the patient's homeostasis and body response to therapy at this point of time. So if you are doing a blood gas at 4 a.m. in the morning and you're going to interpret it at 8 a.m. and act upon it at 10 a.m., it doesn't serve the purpose and it's probably going to be wasted resources for the patient. So always try to act upon an ABG as soon as the results are available to you. The second point we should remember is that every blood gas should be assessed whether it is reliable and it is interpretable correctly or not. For that, you would need a venous bicarb, which is then fed into the Henderson-Hasselbalch equation, and then you know how to calculate the validity of a blood gas. There's no point in running the bicarb test in the same blood gas machine because it's like taking evidence from the thief. So the blood gas will tell you exactly, give you the same bicarb which it's showing on the arterial blood gas. So the lab should have the capability of testing the venous bicarb by a method other than the routine blood gas analyzer. Labs which do not have this kind of a blood gas analysis, independent analysis of bicarb, can choose to use another blood gas machine which is always inferior to an independent assessment, but it also can validate the machine in which you are going to interpret your ABG from. So that is the most important aspect we need to remember. Having made sure that this is one of the these are the two important crucial aspects of interpreting blood gases and their relevance. Let us also first start with what is the basic aspect of understanding a blood gas analysis. The basic understanding of a blood gas analysis is that you start with interpreting the pH. Now the be all and end all of blood gas analysis is the pH. So you always have to try and explain the pH for the patient before you say that this is the primary disorder. The reason why I am saying that is the abnormality will push the pH in its direction always. So if there is an acidemia, the pH will be acidotic, and if there is an alkalemia, the pH will be alkalotic. This is in primary simple acid-base disorders. There may be situations where the pH is normal but the CO2 and bicarb are abnormal. Those are mixed disorders, which we will talk about shortly. So when you see the pH they should know what is the normal range of pH. 7.35 to 7.45 is the normal range of pH. Some people believe 7.44, but rather than do hair splitting on this, let us accept that it is 7.35 to 7.45. So a pH less than 7.35 is an alkalemic pH, acidemic pH, and a pH that is more than 7.45 is an alkalemic pH. So once you know that there is an acidosis or an alkalosis, you tend to look at the carbon dioxide and the bicarbonate and the pattern and the correlation of the pH to the CO2 and the bicarb. For example, if a patient has an acidemic pH, you see where the carbon dioxide and the bicarbonate are drifting. So the rule is that if the pH, the CO2 and the bicarb are going in the same direction, you are dealing with a metabolic problem. For example, if the pH is less, the carbon dioxide is less and the bicarbonate is less, you are looking at a metabolic acidosis. If the pH is more than 7.45, the bicarb is more than 24 and the CO2 is more than 40, you are looking at a compensated metabolic alkalosis. But if the pH is going in a direction that is opposite to the direction of the carbon dioxide and the bicarbonate, you are dealing with a respiratory problem. For example, if the pH is less, that is less than 7.35, the CO2 is high and the bicarbonate is high, you are looking at a respiratory acidosis. If the pH is more than 7.45 but the CO2 is less than 20, is less than 30 and the bicarb is less than 15, you are looking at a patient who has a respiratory alkalosis. So the pH and bicarb and carbon dioxide going in the same direction should make you think about a metabolic problem. The pH going in a direction opposite to the direction of the bicarb and CO2 should make you think of a respiratory problem. Having said that, you have understood the direction of the pH and the CO2 and the bicarbonate. Once you know that the pH is acidotic, you see what is driving the pH low. So if the pH is low, you either have a high bicarbonate, a high carbon dioxide, or you have a low bicarbonate. So if you have a high carbon dioxide, you are looking at a respiratory acidosis, and if you have a low bicarbonate, you are looking at a metabolic acidosis. The opposite is also true. If you have a pH that is more than 7.45 and you have a low carbon dioxide, you are looking at a respiratory alkalosis, and if you have a high bicarbonate, you are looking at a metabolic alkalosis. So once you know that the pH is low and you identify the primary driver, you apply the rules of compensation. A metabolic disorder is usually compensated by a respiratory compensation, and a respiratory disorder is usually compensated by a metabolic compensation. The metabolic compensation usually takes about 48 hours to set in. Therefore, you have acute respiratory problems and chronic respiratory problems, whereas the metabolic problems are instantly responded to by the lungs because of the chemoreceptor zone in the chemoreceptors in the respiratory center. So there is nothing called as a chronic metabolic acidosis and a chronic metabolic alkalosis. There is only metabolic acidosis and metabolic alkalosis. Let's start with the simplest and the most common disorder which is seen in the intensive care unit, that is metabolic acidosis. As we have discussed before, in a patient with a metabolic problem, the pH, the CO2 and the bicarb will go in the same direction. So, in a patient with metabolic acidosis, the bicarbonate will be low. That is the predominant disorder, as a result of which the pH will be low. And to compensate for this, the carbon dioxide will be washed out, so the carbon dioxide also will be low. So if a patient whose pH is low, bicarb is low and CO2 is low, is most likely to have a metabolic acidosis. Once you know that there is a metabolic acidosis, you apply the rules of compensation and see whether that carbon dioxide is compensating for the loss of bicarbonate. The rule you apply is called as the 1.5 plus 8 rule, that is 1.5 times the bicarbonate plus 8. So if somebody's bicarb is 12, for example, 1.5 is 1.5 into 12 is 18 plus 8 is 26. So this patient should have an expected CO2 of 26 plus or minus 2. So now suppose this patient has a CO2 of 30, which is more than 26, despite the fact that it is an alkalotic range carbon dioxide. For that patient, for that bicarbonate, this is respiratory acidosis. So if somebody with a bicarb of 12, instead of having a carbon dioxide of 26, has a carbon dioxide of 30, it means the patient has a primary metabolic acidosis and a primary respiratory acidosis. Now, when you report such an ABG, if there is no secondary, if the compensation is perfectly normal and this patient had a carbon dioxide of 26, you would report this as metabolic acidosis with respiratory compensation. If the patient had a carbon dioxide that is higher than this, you would report it as metabolic acidosis with compensation plus a primary respiratory acidosis. So if somebody has a CO2 of 26 with a bicarb of 12, you don't report as metabolic acidosis with respiratory alkalosis. You call it as respiratory compensation for metabolic acidosis. Similarly, you have a compensation for metabolic alkalosis, that is the 0.7 plus 20 rule. So the 0.7 into the bicarb plus 20, you will get the compensation for the expected carbon dioxide for that degree of metabolic alkalosis. Now, metabolic alkalosis is sometimes a problem in the intensive care unit. If you give too much of furosemide to these patients, that is diuretic to these patients, they develop a metabolic alkalosis. And to compensate for the metabolic alkalosis, the patient hypoventilates and retains the carbon dioxide. And if you look at the picture, just the number of carbon dioxide and interpret it as a respiratory acidosis, your treatment is actually going to go in the wrong direction. You tend to give the patient BiPAP, as a result of which he can't trigger, he will retain more carbon dioxide, and you keep on decompressing the patient by giving more diuretic. You think it's cor pulmonale, and you will perpetuate a vicious cycle. So always interpret the pH in the context of the bicarb and the CO2, and see which is the primary disorder and which is a compensation. Now, as I said, when you have a patient with metabolic acidosis, you also need to understand what type of metabolic acidosis this patient has. There are two types of metabolic acidosis: high anion gap metabolic acidosis and a normal anion gap metabolic acidosis. High anion gap metabolic acidosis is usually more common in the intensive care unit, and it is seen in conditions like DKA, hepatic failure, uremia. There are so many differential diagnoses. There are lots of mnemonics which speak about high anion gap metabolic acidosis. So the anion gap is calculated by the sodium minus the chloride plus bicarbonate. Previously, potassium used to be considered in the formula, but of late potassium is no longer considered in the formula for anion gap calculation. One important thing you need to remember about anion gap is that it is closely related to the albumin concentration. So for every 1 gram drop in albumin, you should add 0.25 to the measured anion gap. So in a hypoalbuminemic patient, before you declare an anion gap as normal, you have to make sure that the albumin is more than 3.5 grams per deciliter. Once you know that this anion gap is high, you need to understand the etiology, and you also need to look at the osmolar gap. The osmolar gap is the difference between the measured serum osmolarity with the osmometer and the calculated osmolality which you use by the formula which you know to calculate the osmolarity. High osmolar gap, high anion gap metabolic acidosis is most commonly seen in ethanol intoxication, methyl alcohol poisoning, and ethylene glycol toxicity. So once you know that there is a metabolic acidosis, you have to see the anion gap, and then you see whether there is a high anion gap or a normal anion gap metabolic acidosis. The important point, learning point you need to remember is that whenever there is a high anion gap, there is always a metabolic acidosis. The other way around is not always true. That means every patient with metabolic acidosis will not have a high anion gap, but nearly everybody with a high anion gap will have a metabolic acidosis. If the patient has a normal anion gap metabolic acidosis, you need to look at the urinary anion gap. The urinary anions minus the urinary cations will give you the urinary anion gap, which is usually between 0 to 10, but some people consider 0 to 20. An anion gap of more than 20 would mean a renal cause of normal anion gap metabolic acidosis, like a renal tubular acidosis. A normal anion gap acidosis with a normal urinary gap anion gap would suggest a gastrointestinal cause of normal anion gap metabolic acidosis. Sometimes there may be a combination of high anion gap metabolic acidosis and normal anion gap metabolic acidosis, which you can identify by calculating the delta ratio or the delta gap, which is the ratio of the delta change in anion gap to the delta change in bicarbonate, the target being 1.1. So anything less than 0.4 would mean a pure metabolic normal anion gap metabolic acidosis. So that's about metabolic acidosis. Now the respiratory problems are a little more complex because the respiratory problems have an acute component and a chronic component because the mechanism, the compensation happens at the renal tubular level. The juxtaglomerular apparatus and the countercurrent mechanism in the renal tubules will be able to compensate for a higher carbon dioxide in about 48 hours. So you have acute respiratory acidosis, acute respiratory alkalosis, and chronic respiratory acidosis and chronic respiratory alkalosis. In an chronic respiratory alkalosis is not usually seen in clinical practice except in the pregnancy, but acute and chronic respiratory acidosis are very commonly seen in intensive care practice. If you paralyze a patient during surgery and don't ventilate them properly, they come back to the ICU on the tube with acute respiratory acidosis. COPD patients are the prototype of patients who have chronic respiratory acidosis. The difference is the amount of renal compensation. In acute respiratory acidosis, for every 10 millimeters increase in the carbon dioxide, the bicarbonate rises by 1. That means the kidneys try to conserve bicarbonate for respiratory acidosis by producing a metabolic alkalosis. Whereas this ratio is 4 millimoles of bicarb conserved for every 10 millimeters increase in carbon dioxide. So the rule is 1 for 10 and 4 for 10. For example, if somebody has a CO2 of 80, right? So 80 minus 40 by 10, that is 80 minus 40 is 40, 40 by 10 is 4, 4 into 4 is 16. So the expected bicarb for this patient is 16 more than the normal upper limit of normal, which is 24. So this patient is expected to have a bicarb of 40. But if this patient has a bicarb of 30, while he is expected to have a bicarb of 40, despite the fact that the bicarbonate is higher than 24, you make a diagnosis of metabolic acidosis on a background of chronic compensated respiratory acidosis. So we do not therefore interpret a blood gas just on the basis of either the CO2 or the bicarbonate, but its effect on the pH and the rules of compensation. Similarly, there is a 2 for 10 and a 5 for 10 rule. The 5 for 10 would mean that there is a 5 millimoles per liter decrease in bicarbonate for every 10 millimeters decrease in carbon dioxide in chronic respiratory alkalosis. In pregnancy, the normal CO2 upper limit is about 32, and therefore the bicarb also will be a little less in pregnancy. So this is the way you interpret blood gases. First, look at the pH, the direction of the pH vis-a-vis the direction of the CO2 and bicarbonate. What is the direction of the pH and what is the impact of the carbon dioxide and bicarbonate on the pH, and the correlation between the rules of compensation and the gaps you have to identify. The gaps are the anion gap, the delta gap, the osmolar gap, and the urinary anion gap. So if you have this concept, your interpretation of blood gases will be very smooth. If there are any comments, if there are any queries, you want more clarification, please do post on the CritiLearn and Higgs WhatsApp groups after you watch this video. Thank you for joining us and happy learning. Bye bye.